Hi, everyone. My name is Dr. Roopa Dhatt, and I'm the Executive Director and co-founder of Women in Global Health. Today, I'll be moderating today's session, and welcome to our session on a world imbalanced sepsis and inequity. We will be really talking about issues of equity in relation to sepsis and COVID-19 and beyond in a broad sense of way. We'll be looking at health outcomes through an intersectionality lens to demonstrate that health inequities based on gender, sex, race, age, ethnicity, health workforce safety, and resource limitations. As this past year has shown us, there are inequalities within society that are widening. The inequalities have been magnified. And as this Congress brings together esteemed speakers, I am delighted to really kick off this session where we get to talk about these important issues from a intersectional approach. The format of this session is going to be presentation followed by a Q&A format, and just some reminders that we'd really like you to use the chat function to submit your questions for our speakers to keep this engaging and interactive. I also encourage all of you to engage in social media with the Congress and provide your comments and just engage with us from that platform as well. And so some other reminders that we have are that we'd like to particularly acknowledge all the partners and sponsors that made not only the Congress possible, but this particular session. So thank you for your partnership. On that note, I'm really delighted to kick off the panel. If you have any questions or comments, do use the chat function. I will be keeping track of that. And a friendly reminder that our speakers, if you want to get to know more about them, their extended bio is available on the website. We encourage you to check out the website to learn more about each speaker, but I will be providing a brief overview and introduction. So on that note, as we kick off this really exciting session, I'd like to invite our first speaker, Dr. Mamta Swaroop from Northwestern University, United States. Dr. Swaroop is a dynamic, collaborative, visionary academic, global trauma surgery leader. She has been invited in national and international roles, visiting professor and keynote speaker, and authored over 65 peer-reviewed articles and book chapters. She's chaired numerous symposiums and mentored over 100 rising leaders. For over a decade, Mamta has excelled as a trauma and acute and critical care surgeon, researcher, and mentor at the Northwestern Memorial Hospital. She also has started her own lab called the Sadhana Trauma and Surgical Initiative, as well as has her 501c3 nonprofit, the Sadhana Foundation, which aims to build sustainable access to surgical care and healthcare through education and research in low resource settings. And one of the other fun facts about her is that she is well recognized, including one of Oprah's health heroes. So Mamta, I invite you to the floor to provide us an overview of factors underlying racial and gender disparities in sepsis management.
I'd like to thank the organizing committee of the World Congress for allowing me the privilege of presenting on this very important topic. I have no disclosures. To start this conversation, I believe it's important to define a few key terminologies. First and foremost, I'd like to discuss what exactly is a health disparity. A health disparity, to describe any difference in health status, health outcome, and healthcare use that reflects a gap in the quality of care delivered and may be caused by a societal inequity, for example, differential socioeconomic status, and patient, provider, or system-level factor that results in differential treatment. Structural racism. Next is a key component of words that we hear in this space, and one of those is structural racism, which is the totality of ways in which societies foster racial discrimination via mutually reinforcing inequitable systems. And then we have implicit bias, the association of negative attitudes to individuals based on irrelevant characteristics such as race or gender. This has been observed among healthcare professionals. These disparities in sepsis care and in overall health care are seen globally. During my presentation, I will be presenting US-based data then could be extrapolated somewhat specifically, the structural racism bit and implicit bias pieces to other countries and their own systems of inequity. I am not saying that all inequity is created equal. All I'm saying is that some of the themes are definitely similar. I will talk about disparity as a patient would go through our clinical system. So first we'll talk about incidence, then we'll talk about presentation. We'll conclude our time together with some goals for transformation. So first we'll start with disparities and actually who gets sepsis. So first and foremost, men and older populations, people who are immunocompromised, people who have chronic diseases, and those in the African American and Black race also tend to get higher incidence of sepsis. Additionally, neonates, in the neonate population, there is a very high parallel in insurance payer status, income, race and gender, and sepsis mortality. And this is all despite standardization of care with evidence-based bundles, and the disparity is very wide amongst races. And although there is some genetic variability in host immunological responses and modulation, most of these studies that have been done are predominantly done by and through having whites patients. They are very small sample sizes for any of the other races. Other things that contribute are, as we spoke about briefly, chronic comorbid conditions. And so there tends to be in Black and African American population higher rates of comorbidities. This increases the risk of acute respiratory failure and sepsis, as well as acute kidney injury. And patients who are Black and African American are usually younger and have diabetes and chronic renal failure, as well as obesity and HIV. Additionally, lower socioeconomic status and minority race tends to equivalent with poor health, lower rates of health insurance, and therefore less access to preventative healthcare services and primary care. Minorities who have lower socioeconomic status and live in rates with high layers of rates of poverty have an increased incidence of acute critical illness and severe sepsis. Racial bias and racial segregation affect health by limiting the social determinants of health: education, employment, quality of life, healthy fitness, access to medical care, and they also increase exposure to environmental toxins and stressors. And there isn't any precise measure of racial discrimination available. Most of these studies are done based on surveys and perceived attitudes and behaviors. And here we see implicit bias. So now we'll touch base on some clinical presentation, and I'd like you to keep in mind implicit bias and structural racism and how that impacts our patients' decision-making throughout the rest of my talk. So now we're at how these patients present. And so patients are unlikely, when they're minority, Black, or African American, to be vaccinated in the elderly population. And as these poorer patients have no health insurance, they have a greater burden of comorbidities. And they also have delays in seeking medical care. And because they delay their seeking medical care, they often present very ill, and they have a higher risk of acute organ failure and present to the hospital quite ill. Black and African American patients tend to be sicker at the time of cardiac arrest. Also, they have higher usage of alcohol, and they have alcohol use disorder, which is most common in Black and African American patients, Hispanic patients, and Native American patients. And this causes these patients to have a higher severity of illness, rates of sepsis, acute lung injury, organ dysfunction, pneumonia, and post-op complications. And here you see a lot of mistrust in behavior patterns, as well as things that you could say are coping mechanisms for environment. So let's touch base on the clinical management now. Non-white patients are actually admitted to the ICU less often. And this is regardless of when they're risk stratified and they just happen to not be admitted to the ICU as much. And Black and African American patients wait longer to be admitted to the ICU from the emergency room. They also are less likely to be discharged to another medical facility after an ICU stay. Now, some of this may be because there are younger patients and some of them have better family, family support, but this definitively needs to be more well studied. And some of the care that is provided is secondary to the safety net hospitals that are giving this care. And a lot of times it's secondary to the financial constraints and the limited quality improvement. Again, I'm stressing this poor, the poverty-stricken areas and the no health insurance, because no health insurance leads to so much disparity in every aspect: access to healthcare, clinical management, and outcomes of patients. And then in preference for end-of-life care, African American and Black patients, as well as Hispanic patients, have very much desire for aggressive end-of-life care. And this is regardless of whether or not the care is successful and improves outcome. And there are studies that suggest race and ethnicity may contribute to discordance between physician communication with patients and surrogates. And a lot of that also has to do with the mistrust that is within the patient populations. So now outcomes. In mortality, males and African American and Black patients have a higher mortality of 1.5 to 3.5%. And they have worse outcomes related to quality of life, emotional and neurobehavioral complications. They have less community integration, and they have higher levels of post-traumatic stress disorder. And again, because of this, we touched on this briefly, likely because of the not having insurance, they are not transferred to post-acute facilities. So all in all, elderly patients, frail patients, and impoverished patients suffer the highest risk of septicemia deaths. Black and African American patients suffer a disproportionately elevated septicemia mortality, and Black and African American patients have racial disparities within the domains of SES. These are two charts that are good combinations of everything, and in case the slides are posted, I kept those. So now talking about transformations, how is it that we can actually take everything that we've heard and put it together to make changes? So if we had quality improvement initiatives focused on the safety net hospitals, perhaps we can make some actual change within the system that will change care for any race of patient who is taken care of at a particular hospital. If we can improve access to care, which of course is the key to everything, which would allow primary care facilities to be more accessible, allowing education to permeate through, and then enrolling patients who are actually eligible for insurance, that would be fantastic. And then empowering communities through community-based interventions like community-based CPR, et cetera. But I think the ultimate truth would be to build trust within our community. Now, how actually to do that? I think by any of these above, as I've stated, and number two would be with higher level, policy, et cetera, working on the social determinants of health. So all in all, I think that this transformation slide, if we could work on these things, I think that we would be able to build trust within the community and perhaps affect the factors that lead to racial and gender disparities. Thank you.
Thank you, Mamta, for such a great presentation and overview, and really sharing us with the data on the context in an intersectional way. So as the questions that really came in, and it goes back to a point that you were emphasizing is really, in the United States, for example, there is very little coverage. What we call universal health coverage is not a reality here in the United States, and financial barriers are a key driver as well. There was a question that came in the chat regarding, is there any country that has a good model on equity or where they have been able to achieve equality? And if you could also in your answer cover briefly what the difference between equity and equality are and why you're focusing on equity in your chat.
So I think that I'll take the second part of that question first so that my mind has a bit of time to think about a good model. So I think equity and equality, in essence, equity allows every individual to get what they need from the system to be successful. Equality means that we give everybody the same things, and that's it. So by giving every individual the same, that doesn't really allow them to be successful. However, there are different things that different people need to be successful. And so that's why I'm focusing on inequity and equity versus inequality, because every person doesn't need the same things from the system or from one another. And I think that it's important to focus on equity, not necessarily equality. And when I think about the system and what is a good system, oftentimes I think about the NHS, right? And there are definitively many problems with the NHS. There's definitively many problems with the Canadian system. There are many problems with a lot of these socialistic medical systems. However, they do allow for every individual to get care and emergent care as is needed. I still remember that my father and my mother, when I was younger, were able to get milk cards, and everybody was given milk cards. So I think that that's a wasted resource because every individual doesn't need milk cards. And so there are definitely things that are wasted and are more towards equality than equity, right? And so every system has things that needs to be tweaked. But I think some of these systems are definitively good systems to look at. And I don't think that there is a perfect system quite out there. Thank you.
Great. Thank you, Mamta. And, one of the comments that came in is, particularly if I understand correctly, social and environmental factors have a more significant role in sepsis outcome rather than the genetic aspects of it. So I think your presentation really drove that home and challenging all of us to look at things from a social determinants perspective. So thank you, Dr. Swaroop. On that note, I'd like to transition to our next speaker, Dr. Queen Dube from Queen Elizabeth Central Hospital, Malawi. Dr. Dube is a consultant pediatrician and clinical epidemiologist. She is also the Chief of Health Services for Malawi's Ministry of Health. She has previously been the head of pediatrics and child health at Queen Elizabeth Central Hospital, and which is one of the largest tertiary hospitals in Malawi, in a position she's been holding for some time. She brings an experience of working with a wide range of global health actors in her Ministry of Health role. She led the initiative on saving newborn lives, saving children, working with USAID, WHO, UNICEF, and many other actors. She has a long career in also collaborating with other ministries in countries such as Namibia, Botswana, Zambia, Ethiopia. And this is just a bit of her extensive background. Dr. Dube, I invite you to the floor to provide us an overview of fetal and maternal care and profound impacts that deserve a brighter spotlight.
Thank you very much, Dr. Dhatt. I hope I pronounced your name correctly. So over the next 8 to 10 minutes, I'm going to talk about fetal and maternal care, profound impacts deserving a brighter spotlight. Now, when you look at births across the globe, you will see that 11 million actually occur in the high-income countries and predominantly in health facilities. And if you move down to the lower figure, we still have quite a number of births that are still occurring at home. And we've moved quite a lot in terms of women coming to deliver in the facilities. But the bottom picture shows you the true situation on the ground, particularly in the African region, but also in Asia, where you have multiple babies sharing one cot. I'll come back to this later on, because when we talk about the mother newborn dyad, in as far as sepsis is concerned, prevention is better. And having facilities that can allow us to adhere to IPC procedures is really critical. Now, we know that when a mother has an infection, the fetus is also at risk. This is an amazing pair that share so many things. And unfortunately, they can also share infection. A very good example is choriamnitis, which is an when the ascending infection reaches the uterus, the fetus can be actually affected. And the impact can be both in the short term, but also long term, where you can end up with a neonatal infection. The mother can go into preterm labor. And we all know the complications around preterm birth, hypoxic ischemic encephalopathy. And this is one of the major causes of cerebral palsy in our settings. And then there's a long list of other injuries and complications. So when we talk about maternal infections and the impact on the baby, the impact is huge, both in the short term, but also in the long term. It has major bearings, even on the economy, but also the social economic dynamics of the families that are actually affected. And this picture just shows us the pathophysiology on how the fetus can end up with hypoxic damage to their brain. And essentially, it's all because of some of the fetal cells that are in the brain that can actually die as a result of an infection that has been gotten from the mother. Now, we've known this over the past several decades, and we've known what it is that we need to do to prevent and better manage infections. I took this from the World Health Organization website, where it was screaming maternal sepsis can kill. By taking early action, you can save lives. And they talk about these 3 basic steps: practice clean care, make an early diagnosis, and treat promptly. So for the next few minutes, I'm going to really tackle the middle bit, which is early diagnosis. And I'll touch a little bit on practicing clean care. Let me also underline the fact that over the past decade, we have seen 3 major shifts in as far as maternal and newborn health is concerned. There is no lack of evidence. So we have powerful evidence base. What is it that is causing maternal sepsis? What is it that is causing fetal sepsis? We have seen a lot of movement around political will. So our political leaders have signed up to all these agreements, SDG targets. They've signed up to, even within our region, within the Quality, Equity, and Dignity Network, to even go beyond and not wait for 2030, but get things done earlier than 2030. We've also seen critically that the place of birth has changed. So we used to struggle with a lot of women delivering at home, but now they're coming to deliver in the facility. And that brings them within our own care and management. But when you look at the data for maternal infection and fetal neonatal infections, you will see that we haven't moved much, even though the women have come to deliver to us, which brings in the element of quality of care. And so thinking through, when you look at this maternal sepsis agenda issue, we really need to think through it using the health system building blocks. What is it that we need to do in terms of data, leadership and governance? What policies are there that drive the reduction of maternal and neonatal sepsis? Human resources, medicines and technologies, but also financing. I'll come back to financing later on in the talk. Now, Malawi is one of the countries within sub-Saharan Africa, and 85% of our people live in the rural areas. And this is one picture that I took from the net. This is not Malawi. This is a picture of Uganda, just to underline the fact that it's not just one sub-Saharan Africa, but this is the truth in a lot of the sub-Saharan countries. And this is where the back of our women are coming from. We need to keep this at the back of our minds when we're discussing this element of prevention, diagnosis, and treating early. Now, one of the major hurdles is investment in diagnostics. A lot of what we call maternal sepsis or neonatal sepsis is based on a clinical picture, symptoms and signs, and very little backup in terms of laboratory diagnostics. So you see a lot of unnecessary use of antibiotics because people are confronted with a sick mother in front of them, a sick baby in front of them. They cannot tell which one is actually causing the condition that is in front of them. We cannot tackle this if we don't invest in diagnostics. So investing in diagnostics has two parts. Innovations, we really need to think about where these people are coming from, where there is no electricity. If we have diagnostics that are heavily dependent on electricity, we cannot do it. What about point of care diagnosis? We've seen it with COVID that within a few months, we have point of care tests for COVID. Can't we do the same for the other infections? Now, coming back to the story of COVID, we were all geared to make sure that we attain the SDG targets, and boom, COVID came on the scene. And our health systems were greatly disrupted. But I personally have learned quite a lot from COVID, that it is possible when you have the will, when everybody comes together on one table, you can actually make things happen. And so with COVID, we've seen that it's possible to come up with diagnostic tests. It's possible to strengthen the data systems. It's possible to hire people within a very short period of time. Can't we take the same lessons learned from COVID and translate them to the bigger picture on maternal sepsis and neonatal sepsis? Otherwise, we'll continue to sing this song of antibiotic resistance with all the major impacts of antimicrobial resistance that we've talked about over and over again. But if we don't invest in the proper infrastructure, IPC measures, diagnosis, proper treatment, and follow-up for these women, this will be a story that we'll talk for the next decade. Let me remind everybody else that antibiotic resistance will disrupt the Sustainable Development Goals, will disrupt issues around poverty, good health and well-being, reduced inequality, zero hunger, decent work, and economic growth. Let's not take this seriously. Finally, every mother newborn deserves to live. Even in that rural part of Africa, in Asia, they also deserve to live. Thank you.
Thank you, Dr. Dube, for such a powerful presentation and providing those stark examples. And a question that came from the audience, and this is something that you already set up as you were closing, is that we must, reach every woman, every child, every infant. So what would you say is how can we reach those women that are living in rural areas with preventative measures and the women that are the hardest to reach?
Thank you, Chair. So two things really. We need investment around this area. I spoke about the fact that these women are now coming to us. If you look at antenatal care coverage, they're coming to us. even from these hard to reach areas. For Malawi, antenatal clinic attendance is above 90%. So they're coming to us. But when they come to us, they come to what kind of an environment? There's a lot of congestion. Supplies is an issue. When they spike a temperature, do I have the possibility to make a diagnosis? Do I have a functional lab? So bringing these women to us is not the issue on the table. It is us giving the women that which they deserve.
Really clearly articulated there, Dr. Dube. And, your also point about the diagnostic testing is actually very timely, and how these, lessons from COVID-19 should be taken forward. A piece of work done by FIND and Women in Global Health actually looked at getting testing into the hands of women, and many of the points you raised about, women not even having the tools necessary to get the appropriate diagnostics is another key pillar for broader achieving health equity and improving health outcomes. So really well-rounded presentation. I wish we had more time to dive deeper into this, but please, I encourage everyone to use the chat function, submit your comments, questions. Our speakers are engaging in the platform, so they can also answer that way as well. So on that note, I'd like to introduce our next speaker, Dr. Were, who will be providing us an overview of combating sepsis to achieve the Sustainable Development Goals, a great transition from the points that Dr. Dube raised. And particularly Dr. Were's background is that he works for the World Health Organization, is a senior medical officer in the Child Health Services in the Department of the Maternal, Newborn, Child and Adolescent Health and Aging in Geneva, Switzerland. He's a technical lead and responsible for child health policy, strategy, and practice guidelines. Before joining WHO, Dr. Were is a Ugandan pediatrician specialist in public health and has over 25 years experience working in this space. He has spent 15 years living and working as a physician in Africa in countries such as Uganda and Zimbabwe. So he has a breadth of experience at the global policy level, but also at the country level. So on that note, I invite you, Dr. Were, to the floor to please provide us an overview on combating sepsis to achieve the Sustainable Development Goals.
Thank you, Dr. Dhatt, for the introduction, and thank you for giving me this opportunity and privilege to participate in this Congress. So I'll look at really place the sepsis in the global health agenda and how combating sepsis is really critical in achieving the global targets we have, especially the SDG 3. And basically, when you look at the global burden of sepsis, I want it to be looked at in two ways. One is that there's a very high morbidity, and that actually means that to combat sepsis, we have to do more investment into managing the cases. The second part is that it is contributing enormously onto the global mortality, global death. 20% of global death is being contributed by sepsis. And therefore, our SDG targets, which are really basically around the reduction in mortality, will really show that actually without combating sepsis, we will not be able to achieve some of the targets we have put across. The second thing I want to put forward is to say that, as already elucidated by my colleagues in the previous discussions, in the previous sessions, is that really among the countries with the highest burden of sepsis are the same countries where we really need to drive the SDG agenda. They are the same countries that are behind the SDG agenda. So it's very, very important for us to put that context as we discuss and move forward on this issue around combating sepsis to achieve SDGs. And just as has been elucidated by my colleague, Dr. Dube, is that maternal sepsis is a big issue. pediatric sepsis is a big issue, and sepsis contributes to the mortality in these two age groups, both in maternal and perinatal period, but also in early childhood. And it's very, very important to realize that if we have to achieve our SDG targets, then we need to address sepsis in order for us to be able to stop this preventable death. Of course, we should also realize, and as it has already been shown in the previous session, that actually patient safety is very, very important. Even when we receive these patients in hospitals, we really need to be able to ensure that along their care pathway, we are able to prevent the sepsis by ensuring that we have very good IPC measures in place. But now, what are the SDG targets that we should be looking at? Just to elucidate this, I wanted to just highlight a few things. One, that sepsis is preventable. And so if we can prevent sepsis, we can reduce maternal, neonatal, and child mortality. And I think that should be at the back of our mind. Because if we don't do that, then we might not achieve the maternal mortality, which is our target 3.1. It will impact our target 3.2, both neonatal and under 5 mortality. But not only that, it will also impact on the target of 3.3, which deals with infectious diseases like HIV, TB, malaria, and other infectious diseases. So it's very, very important for us to look at it in that context. But also, as it has been discussed in the previous session, the issue around care, the care we provide. So if we don't provide universal health coverage, then we might not be able to prevent and have early diagnosis and prompt treatment. So it's very, very important for us to look at it in that context, that all that will affect the outcomes in sepsis. Who is at risk? I think that's very clear. I don't need to go into details in that, but neonates, pregnant women, infants, old people, those who are hospitalized and immunosuppressed are the ones at the greatest risk, and we need to look at that. But I just wanted to also highlight that, and this was also brought up by Dr. Dube, to say that the common problems our children have are the same problems that actually lead to sepsis. The issue is about how are we able to diagnose those in the right time and provide the right treatment. And I think that is very, very important. So when you look at the burden, as I will show you, the major causes of mortality in under 5 are really around pneumonia, diarrhea, meningitis, neonatal infections, and all these are going to be impacted because of sepsis. And if that really means that we need to address them if we have to achieve the SDG targets. And we should not forget that we are already 5 years gone. We are counting down now, we are just 10 years to the SDG targets, and that's very, very important. If you look at maternal causes of death, the progress we have made, yes, but still proportionately, sepsis is contributing a big chunk of that. And therefore, I think the WHO's response has been to really work with the governments and partners to really be able to, first of all, we need to understand the burden of the disease. This is very, very important, but also to provide guidance on sepsis prevention and management, and also have some strategies on how to combat this. And I think that is very, very important, and I'm happy that some of these are being discussed in this Congress. So strategically, I think it's very, very important to look at how we can prevent and then have early recognition. And I think as highlighted, the issue is around how can we recognize sepsis early enough and take action. And this really means that the health systems should be responsive. I think I liked at the beginning of the session today, this afternoon, where Jeremy Hunt gave those stories. How can we make sure that those stories don't repeat themselves? So there are two areas that we need to focus on. One is the primary prevention. And for me, this is the most important, especially in the vulnerable populations, that we should be able to improve their hand washing hygiene, improve availability of water, but also make sure that they're able to reach the services they need. And then the second, the prevention, which is really prompt recognition and treatment, which really depends on which health system you are in. So we need to look at the health systems and see how we can support them deliver on this. And of course, the issue around case management, which is very, very important, because if once we have had the diagnosis, we should be able to provide the care that these people need. And of course, depending on the system, to be able to support those that need our support. But I wanted also to highlight the challenges. I think we should not forget that we have challenges, especially in the countries where we are having a big burden and where countries are behind on their SDG targets. Scaling up of preventive measures is very, very important. The issues around proper diagnosis, I think like it has been highlighted before, and of course the antimicrobial resistance that we should all recognize that is going to impact on this. So there's still a danger that we might not achieve SDGs unless some of these things are addressed. Of course, the gaps, we still have gaps, and we need to look at these gaps in order for us to be able to address the issues, and especially around the diagnosis. How can we simplify recognition, both by the parents, but also by the primary level healthcare workers to be able to recognize? So in conclusion, I want to say that really, without us addressing sepsis, we shall not be able to achieve the sustainable development goals, because the mortality, maternal mortality, newborn mortality, under 5 mortality, sepsis contributes a big chunk of that. So if we don't combat sepsis, we may not achieve those targets. So we need to have a global effort concentrated on combating sepsis in order for us to achieve our SDG target. Thank you.
Great. Thank you, Dr. Ware, for your presentation and also making the connectedness of the agenda of sepsis to the SDGs, and especially the SDG 3 on health and well-being. You've received a few different questions, and I'd like you to see if you can try to answer them. A lot of them really go down to what's happening at the country level. How many low and middle income countries are actively working on national initiatives to fight sepsis? Secondly, what's come in is what improvements have we done globally in terms of providing access to sanitation and healthcare to the most poorest populations in the world, as it's been mentioned that these are also the countries with the greatest burden of sepsis.
Thanks very much for that. So I think there are various steps that have been taken to do this. One, I think, is that all governments recognize that sepsis is a big area that needs to be addressed. And by coming up with a WHO resolution, meant that governments have politically made commitment, like my colleague mentioned, that political commitment is there. The second aspect is that a number of countries have devised strategies on how to address most of the challenges that lead to sepsis. As I talk now, we have provided even guidance around how do you address newborn sepsis, even at community level. How can we get and be able to pick those children at community level and be able to manage them and prevent the consequences of sepsis? So that is there. The third thing that I think which is very, very important is that countries are looking at this as part of their strategies to achieve the SDG agenda. Most countries have very clear strategies, and what we need as the global community is how do we support these national strategies to be put in place to address the agenda. In terms of water and sanitation, I think there's a big effort as we talk now that a number of countries are working, even looking at not only even in the communities, but even in our health facilities. You'll be surprised that a number of our health facilities even lack adequate water for them to actually even practice the IPs we are talking about. There's a big effort, and a number of countries are really looking at how to improve their water and sanitation. I would say UNICEF has taken on this as is a leader in this area. On our side, we are really working around the health facilities to improve water and sanitation, because it's very, very important. Like somebody said, if these women are coming, we should make sure that we are going to offer them good services. Thank you.
Great, thank you, Dr. Hawari, for emphasizing that. And Dr. Dube had come back on this question on the political will that was raised, and Dr. Hawari, you talked about it too. The political will in signing documents is great, but we really need to go beyond that into seeing investments in particular areas, particularly in the case of sepsis. We need to see investments in health workforce, training, infrastructure, equipment, supplies for diagnosis, information systems, tracking sepsis, and accountability frameworks. So, again, building on this theme, I'm delighted to invite our next speaker, who does not need an introduction, but I will still provide an introduction, is Dr. Niranjan, also known Tex Kissoon, from Global Sepsis Alliance Canada. He is the current president of the Global Sepsis Alliance and the past president of the World Federation of Pediatric Critical and Intensive Care Services. He's held additional roles such as being the vice president of medical affairs at BC Children's Hospital and is a professor pediatric and surgery and emergency medicine at the University of British Columbia in Vancouver. And clearly he is a big advocate of addressing the issues around sepsis and equity. So Dr. Kissoon, I invite you to the floor to provide us an overview of the disproportionate burden of sepsis, especially in children.
Thank you very much, Roopa, and I'm really, really pleased to be here. I must say that my colleagues so far, Queen and Wilson, have really done a very good job and makes my job a lot easier. And indeed, the morning session with Chris Murray, Jeremy Hunt, and others, Keith Martin, Hans Klug, have also put the sepsis in the light it should be. And it is not only a clinical disease, there are other policy and politics that plays into it, as Queen also mentioned. Now, this issue of sepsis in children, when I started out years ago, was quite a lonely sphere in which to work. But over the years, I've gotten to know some stalwarts in the field, Queen and Wilson and Farhad, and they have made it a lot easier and the burden a lot easier to carry. Now, some of what I was going to say, Wilson has already mentioned and Queen has mentioned some. So what I'll try to do is bring context to what they have said so far. And the first thing I like to mention is that for me, I think of sepsis as a medical problem. We've heard the etiologies, delayed recognition, treatment, etc. It's a socioeconomic problem, as you heard Mamta mention some of that, the issue of poor education lead to poor health-seeking behavior, power distance index, no money. In societies where women are not empowered to take care of their children, it makes the problem a lot worse. It's a political problem that deals with government priorities, as Keith mentioned earlier on today, staff shortages, poaching of staff, drug shortages, etc. And Paul Farmer said it very elegantly when he said, many political borders serve as semi-permeable membranes, quite often open to diseases and yet closed to the free movement of cures. And there are many inequalities of access can be created or buttressed at borders when the pathogen cannot be so contained. And this is exactly what we are seeing in the present COVID era. And I think we've seen the inequities. COVID has really laid bare the ugly underbelly of inequities across the world. And the point I'm trying to make it with this issue of sepsis, the reason for thinking of it like this is that we at the clinical side or the bedside alone are not going to solve the problems. As has been said by Lee Garrett years ago when it came to pandemics, we need everyone in society. We need the actors, lawyers, we need politicians, we need clinicians, we need the dreamers and even the poets. Now, You saw the slide from Wilson already, and you can see the disproportionate burden that is born in the younger population is biphasic, as it saw. More than half of the incident cases of sepsis in the world in this Lancet 2 study last year were in children, 41% under 5 years of age, and you can see a quarter of the deaths were related to sepsis and 24% neonatal deaths. So this is high in itself, and it's really stark to show that more so in the neonatal population, while during the Millennium Developmental Goals, we made gains in the under 5 mortality, the neonatal population was left begging for more attention. We heard about the highest burdens being in the sub-Saharan Africa and South Asia, and there is an inverse relationship between socio-demographic index, which is an index of wealth, education, and sepsis incidence and mortality. And one can argue, well, in these sort of areas, the reason why there is a higher burden of sepsis is because of the larger population base in children. And when we look at a population pyramid in sub-Saharan Africa, and this would be similar to Asia, Southern Asia, there's a large pediatric population in many countries. All half the population is the pediatric age group, whereas in Europe or North America, you can see the inverse population. And that was also mentioned by Jeremy Hunt, the population differences. However, I think that the mortality or the burden in children and the mortality and morbidity goes beyond the differences in the population base only. And it has a lot to do of what Queen spoke about: infrastructure, medicines, functional health system, the political will and government, what Wilson has dedicated his career to, and what Farhad is certainly working on at the Gates Foundation. Because when we look at death from severe sepsis and septic shock, a recent study has shown that if we use North America, there are wide variations in the number of deaths or the odds ratio of dying. But if we use North America as a reference, children in Africa are likely to die 8 times more, in Asia almost 4 times, and in Latin America, South America, almost 3 times more. So again, there are disparity, and much of this can be laid bare on the issue of the standard of living, prevention, resources, etc. Now, when we look at other things, we've heard about the issue of antimicrobial resistance, and this has been laid bare as one of the top 10 threats by the WHO and can reverse all the gains in medicine we have. Well, the countries that has the greater number of neonatal deaths caused by antimicrobial resistance are the countries with the highest number or the highest contributor of deaths. And I think that this will not be corrected alone with clinicians at the bedside, but in every strata of society. And Queen has given some of the issues with laboratory, etc. So this is a major problem that, as I said, need advocacy and the will of governments, etc. This is even more stark, and this is looking at pneumonia preventable deaths with access to effective antimicrobials in the under 5 population. And it is we in the sort of well-to-do countries, it is very stark to see that over half of children in many of the poorer countries do not have access to antimicrobial agents. So we have 2 things at play here. We have the issue of antimicrobial resistance in those countries. At the same time, we have lack of access to effective antimicrobial agents. And I think those things go hand in hand when there are no good checks and balances to really get antibiotics to people, right time, right dose, etc. We also have the influence of politics, religion, and celebrity when it comes to vaccine now. And this is a map, the map for the years in 2008, there were very few vaccine preventable disease outbreaks in somewhere in Asia and a few in Africa. Come to 2010, there was a lot more. 2014, it was across the world. And many of those are in children also, a disproportionate burden. And there are a variety of issues there. There's the politics, religion, the celebrities who can sway populations and were anti-vaxxers. And we see this now playing out again in the era of COVID. In fact, it is stark that in some areas, the vaccines are going to lay into waste, even in poorer countries. And we've heard earlier on this morning the issue of vaccine hesitancy from Pauline Patterson, who framed it very nicely and showed the reason where disadvantaged populations who are more likely to get sepsis are more likely to be hesitant or not trust vaccines and trust the health system in general. Antibiotic days that can be averted by pneumococcal vaccine, about 11.5 million days. Again, this is not something that the clinicians alone can solve because big pharma have been overcharging poor countries for vaccines for years. And if the countries cannot afford a vaccine, even now as we see maldistribution with the COVID vaccine, where there are no ethical sort of responsibility to each other, you can see that this is a problem. And this again, the pneumococcal diseases here inadvertently raises the burden in children. Now, come to the era of COVID. We've heard about the Sustainable Developmental Goals, and we've heard that Wilson and Queen has said the issues of gender equality, education, clean water, etc., immunization and prevention all plays into sepsis. Now, the fact is that before COVID, we knew, and Wilson made it clear again, that we need to put our foot down on the accelerator. We needed to increase our efforts in global health for children and maternal health and immunizations. But healthcare disruptions during the COVID period can result in hundreds of thousands of more under 5 deaths. And I think that we have not really seen the final chapter of this story has not yet played out in many parts of the world. We can see what is happening in India today, and I think it's waiting to see what is happening in Africa. At the same time, the pandemic has disrupted immunization in over 70 countries, and we know that illnesses and deaths will spike from trauma and malaria, etc., as has been seen during the Ebola epidemic also. In fact, the estimates have shown that there is reduced coverage because of COVID-19 for childbirth interventions for mothers, parental administration of uterotonics, antibiotics, anticonvulsant, and clean birth environment. And that would account for, the modeling have shown an increase in 60% of maternal deaths, and the malnutrition, in addition to receive coverage of antibiotics for pneumonia, neonatal sepsis, and oral rehydration would account for 41,000 additional child deaths. And when we look at a modeling based on scenario 1 to 3, which is realistic scenario of 10% decrease in healthcare to a 50% decrease as seen during the Ebola period, and using the modeling that was propagated by the Gates Foundation investigators there, we find that based on maternal deaths may range from the low scenario of 25,000 to 113,000, and with child deaths can range anywhere from over 400,000 to almost over 2 million deaths. So this is a big problem, and as I said before, that the final chapter is not yet written, and over the next little while, unless we understand these issues, we understand that models in the rich world will not work for children in the poor world, we are going to be up against it. The other thing is that we've heard about mortality from sepsis, but the mortality is the tip of the iceberg. Strange to say that morbidity is a major problem. And the growing evidence, we know, our group has done a lot of work showing that in-hospital mortality and post-discharge mortality are equal in 6 months post-discharge, and in many cases, post-discharge mortality are higher than mortality in-house. So we have to think in terms of when we how we transition children back to these communities, because many of the post-discharge mortality are not being recorded as such, and hence we are not seeing the full impact. We talk about post-sepsis syndrome, and we've heard a lot of it in adults, and you will hear more about it in other talks on long COVID, etc. Of tired, feeling sleepy, more ill, stress, post-traumatic stress disorder, nightmares. I think the issue that is very different for children is the neurodevelopmental issues in children. And if 40% of children return back for care, and if neurodevelopmental issues continue in a prolonged period of time, we are going to have children who will not achieve their greatest impact, and we are going to be in a society that is poorer for it. And I think that has a lot to do. The implications for children from the resolution is all of the things that has been mentioned: prevention, educated workforce, treatment, etc., disaster and pandemics, inadequate research, and attention to long-term consequences. So I'd like to stop with this. I think that right now, we like to think in terms of we're all in the same storm. Yes, we're all in the same storm with COVID. We're all in the same storm, but we are not in the same boat. And we can see this inequity playing out again and again. And I would like my colleagues worldwide to join us in this quest, because what we do at the bedside is very, very important, but how we advocate around the world is also important. Indeed, advocacy is so important. William Sawyer, the presidential address for the American Society of Tropical Medicine and Hygiene in 1944 said, "No country can live to itself in disease prevention. A failure of one is a failure of all." And Richard Garant, 1997, said, and this is important for children, "The solution to these children problems are the solution to our problems." Of one thing I'm sure, how they and the disadvantaged around the world fare is what will clearly determine the destiny of us all. Thank you very much.
Thank you, Tex, for just a very comprehensive presentation, and also just really making the case of strengthening all health systems, as we are strongest as the weakest health system in the world, and very clear message on that. But related to really the burden of sepsis in children is the impact of adult COVID-19 deaths on children. Can you tell us a little bit more about that too, and how the impacts of adults on COVID-19 deaths are impacting children?
I think that there's so much we can speak about this. And I know, going through and looking at Africa in the days of the big HIV epidemic, we found that there was a lost generation of parents, and those children had to be raised by grandparents who could ill afford supports themselves. When we look at COVID right now, and it struck me how stories matter, and what Jeremy said this morning. And looking at the news, I've seen again and again where families, poor families, in which the parent has to go out and work because they're in the service industry, there are 6 children at home, and they can ill afford rent. They are very much into sort of very food shortages, etc. And this person goes out there, gets sick and die. The family now is left with inability to pay rent, inability for food, etc. And I think this, while children are unable to really voice their opinion in many cases, the loss of all the adults we've heard in this era of COVID has had a tremendous impact. And during the period of time, the young kids, especially those who are in school, the young people, I think that they've impacted greatly by seeing what their parents have gone through: loss of parents, loss of supports, etc. That while children have been relatively spared of the COVID, the emotional toll on them and the stultifying of their possibilities is a major problem that can even be more egregious.
Thank you, Tex. And you're highlighting what's been all throughout the session is the social determinants of health and the interconnectedness of those drivers, and how COVID-19 again has magnified existing inequalities and widened them. And as we nearly come to this end to this really exciting session where we've covered sepsis from an inequity lens, I'd like to invite our final speaker, Dr. Farhad Imam from the Bill and Melinda Gates Foundation in the United States. Dr. Imam is a physician scientist with expertise in maternal and newborn health. He completed his undergrad and medical scientist training in biochemistry at Stanford University, and he joined the foundation in 2017. He has a pretty extensive research background that you can check out his bio on the scientific program for this Congress. And on that note, I'd like to ask Dr. Imam to please provide us an overview of addressing inequities in diagnosis and treatment of sepsis, and provide us the foundation's perspective as well. The floor is yours, Dr. Imam.
Thank you, Roopa, and thanks to Mamta, Queen, Wilson, Tex, the earlier speakers for setting the stage so well for such an important topic with a potential for major impact if tackled. And I really loved, Dr. Wilson, where your statement that without tackling sepsis, we will not achieve our SDG goals. I'll come back to that one in a minute, but I'll start a little more broadly with our goals at the Bill and Melinda Gates Foundation. So we often wonder and try and identify the areas of greatest need and greatest impact, and specifically where those intersect. These are most easily found in areas of health and disease that are often not pursued by the efforts undertaken in the high-income country settings and public research, or in the private sector and pharma. And really nowhere is this more stark than in the areas of maternal and child health, due in part to the aversion and fear to include children and pregnant women, and even premenopausal women in clinical trials due to perceived risk, as well as to the fact that these are less lucrative commercial markets and less developed. And so this leaves women and infants often ignored by the very large and substantial machinery that exists for public and global health, and their diseases truly neglected. So on our team, we wish to turn the lens around and turn the lens of scientific discovery to make sure that new tools that are being built are purposefully driven toward utility for women and for infant health. And so this overview has been provided earlier today in a couple of different ways. I'll just quickly summarize it. So in terms of child mortality, the greatest burden of disease is in sub-Saharan Africa and South Asia. And so you have 93% of child deaths occurring in an area that has roughly half of the world's population. And if you focus further onto neonatal death, there's about a tenfold disparity between settings in low and middle income countries, where the neonatal mortality rate is about 30, in comparison to where all the resources, both from the point of view of healthcare systems as well as devices and drugs, can be at the fingertips of providers, where the neonatal mortality rate is closer to 3. So this this disparity is quite striking, and although on the one hand that's a difficult piece to view and to swallow, the good news is that progress is being made on maternal and infant mortality. And it's if you look at this slide on the left side of the slide, you can see that over a 15-year period, a recent 15-year period, that you have declines in maternal, infant, and neonatal mortality. You'll notice that the most stubborn of those is that bottom line, and is the one that looks the most flat. That is the neonatal mortality rate. And so if we dig a little bit deeper into that, and I'm showing you data here from a study called Amani, which is an analysis of maternal and newborn health and death, the cause of death and etiology I've starred here on these stacked bar graphs for neonatal, maternal, and deaths, as well as stillbirth, the fraction attributable to infection. And you can see that it's quite a significant one. So over a third of newborn deaths are due to infection, as manifested as sepsis, meningitis, and a pneumonia. And over 10% of maternal deaths and stillbirths. And so this is area where we can still continue to make progress. And if we dig a little bit deeper into that data set, you can see here from this Imani study, which remarkably screened over 250,000 births, and this was a prospective community-based cohort of women of reproductive age. So really a tremendous effort across 11 sites in 8 countries, and identified, again, that over a third of deaths, of neonatal deaths, are due to infection, and 70% of those are in vulnerable infants, so either small or premature newborns. And this really lends us also to this underlying theme and lens of vulnerability, where you have certainly infection as courses and bouts of diarrhea, upper respiratory infection, being standard as part of growing up as a child in a world that has an outside environment and that kids are exposed to. All of those of you with small children at home will know that you have some various pathogens circulating, and that's through households, and that's part of growing up and your immune system training. But really what we're finding as we look through the data is that it is recurrent bouts of these normal pneumonias and diarrheas that occur in infants that are already vulnerable to begin with, that are driving a lot of this mortality. And so it's good to know that infection and sepsis is a major area for us to continue to push on to reach these development goals. But so what's our toolbox right now? So there's a prevention side of that toolbox, and that's things like vaccines to babies, practices of care that kind of maximize infection control. You've heard about this in some of the earlier talks. Kangaroo mother care, skin-to-skin care of vulnerable infants with mothers that not only has been shown to be good for growth, but also for decreasing infection rates. So those are all things and tools that we recognize that are being deployed by teams on the ground working on implementation. But what else? What else is in the pipeline? Well, there's also promise from probiotics. There's several trials going on now at phase 3, looking at the role of the infant microbiome and potential dysbiosis as a means for creating high risk for inflammation and potential gut translocation of bacteria, leading to increased sepsis. There's monoclonal antibodies targeted at specific bacteria that are known to be bad players that are being considered for being prophylactically given to neonates. Certainly not something that is in current practice, but as the cost of these drugs go down, and as the ability to do small batch biologics becomes more democratized, these are things that start to fall onto the radar and become feasible for global health. In addition, there's vaccinating mothers to decrease their pathogen burden, because as part of neonatal sepsis, of course, there's the understanding of the role of vertical transmission, not only of good bacteria that set in place the neonatal microbiome that happens as part of the healthy process of birth and of vaginal birth, but there's also the potential for pathogenic bacteria. And so if the maternal pathogen burden can be decreased, there's some thought and some evidence that the neonatal rate of sepsis would also go down. So this is kind of the toolbox in hand, as well as some of the toolbox that's being developed on the prevention side. On the treatment side, we know these pieces well. There's antibiotics and supportive care. This is the more scant part of the basket. And so just framing that as an initial quick look at what we have in our toolbox, we have to ask the question of, can we do better if we don't know more about what we're treating, or I guess rather, can we do better if we were to know more about what specifically we were treating when we call it sepsis? I showed you in the previous slide with the Imani study the role of infection, but what about specific infectious agents? Can we learn a little bit more about that? And fortunately, a few major impactful studies in the past several years have come out to really teach us a lot of important things about what are the bad players causing infection in different environments, as well as not just hospitals, but also in the community. So I'd like to quickly summarize an enormous amount of work over several studies that have begun to answer these questions. CHAMPS, or the Child Health Mortality Prevention Surveillance, is a large multi-center study of child cause of death, including an innovative, minimally invasive tissue sampling method termed MITST, which uses needle biopsy and, as you would expect by its name, minimal sampling, which has a much bigger social buy-in and approval than traditional autopsy. And via this method has been able to really make specific and detailed cause of death determination. And so in the initial study, a third of deaths, and you can see here, it's about 350 neonatal deaths being shown on the graph on the top, that a third of them roughly are due to infection. But and that's the green part, but you see that in preterm babies, it's almost half. And in full-term babies, it's closer to a quarter. So you have roughly a twofold risk of infection in preterm babies, and so therefore preterm babies are disproportionately represented in neonatal deaths because of their, again, underlying vulnerability that puts them at higher risk. And when we look at the agents here that they were able to identify via targeted molecular and culture methods, it's Klebsiella, Acinetobacter, and E. coli. And you're going to see that as a theme that comes in the next the next slide as well. So a couple other studies here that are notable, and these are just a few to pick as highlights among many important studies that have been able to dig deeper and identify details on specific pathogens. Here we have causative organisms from ANISA, which is based in South Asia, 5 sites, over 6,000 cases of clinical sepsis, and they were able, but only 28% attributable to a particular causative organism, and the lead organism of that being a virus, being RSV. So if we think about our empiric treatment, and when we diagnose clinical sepsis, only a quarter of those patients actually have an infection, and the most common infection is actually not a bacterial infection that would be responsive to bacteria. And so here is echoing the problems and the difficulty that some of the earlier speakers said, which, diagnosis and determination of etiology is going to be hugely important for us to not only prevent unnecessary antibiotic administration from a resistance point of view, but also make sure that we're providing the right drugs to the right kids. This is echoed further in terms of how much we have to learn by a study in Delhi termed Dennis, which was from level 3 referral centers that also identified these same 3 bugs very prominently, Klebsiella, Acinetobacter, and E. coli. It identified a higher rate of resistance than some of the other studies that have been done. And so again, there's a mixed bag of how much resistance is there, what are the specific bugs that are there, and how much can I trust my eyes and my clinical sense for a baby an infant that looks septic to actually have a bacterial cause. I wanted to also comment on this that there was less of a difference identified between these traditional immediate or early periods of sepsis where GBS and other vertically transmitted organisms were thought to be predominant versus the late onset sepsis, which was thought to be more environmentally or nosocomially acquired. So that those studies historically, which had predominantly been based in high income settings, this turns out not to be as much the case in this study based in an urban center in Delhi. So then what does this teach us? Well, it certainly helps us provide real world data where to help drive the conversation about best practices in current empiric therapy. And this, what I'm showing here is an antibiogram that's across the street from me, but wouldn't it be amazing to be able to know not only what were the most common organisms in your specific geography, but also what were the patterns of resistance, so that you could more closely target therapies in a, maybe not to an individual personalized way, but at least in a more regional way, recognizing that we now are beginning to have the level of data that allows us to be more regional and to optimize treatments potentially to specific areas. So then what are we missing still? Most of the data I showed you was for targeted studies for known organisms, and most of that is biased by historical potential to grow organisms in a specific kind of culture broth. It turns out that very recently some untargeted molecular methods, metagenomic methods that can amplify evidence of different bacteria and viruses without knowing what they are ahead of time, have been able to really kind of tell us that we've been scratching the surface with these organisms that are easily culturable. This is a study that was done in Dhaka, Bangladesh. You'll hear more about this in a session coming up tomorrow. Where basically cases of sepsis and meningitis that were clinically very ill and had poor outcomes for babies, but were undiagnosed by traditional methods of culture, PCR, and antibody testing, were processed with this metagenomics method, unbiased method, and half of those were solved. And it was never the case that it was one of those usual players, the Klebsiellas, the E. coli's, the GBSs. It was things that one would not have on the map as a clinician, as a neonatologist, as I am myself. Things like chikungunya virus, which weren't thought to cause neonatal or infant meningitis-like picture. Bacillus cereus, tetraparvovirus, things that were thought to be predominantly in livestock, and rare zoonotic crossovers being found commonly, because we weren't looking for them. So I think we're at this really exciting moment where we have better tools to be able to identify and solve some of these age-old mysteries of what are we not seeing and what else is causing illness. We have a level of granularity of data that's emerging that allows us to go beyond country level or global level. And so I think there's a lot of exciting potential here to continue to bend the curve on sepsis. And so with that, I wanted to also just highlight a couple of sessions that are going to have deeper dives into exactly these subjects, one of which is the one that, following this directly, which is going to look at alternatives in the toolbox that, like the symbiotics, the probiotics, like the monoclonal antibodies, and vaccines to moms, or even repurposed vaccines. Another session I wanted to highlight is a session tomorrow that I'll be moderating, which focuses both on AMR as well as this novel pathogen detection piece. So please, if those are pieces that you're interested in, we'd love to welcome you to join those sessions as well. And finally, I'd just like to close by thanking you for your time and attention, and to inviting me for this session.
Great. Thank you, Dr. Imam, for this really great closing, wrapping up session, because it really talks about the importance of data and the potential of really new tools and the role of diagnostics and really understanding sepsis in a whole nother level that has not been possible before. So really discovering new patterns, especially in low resource settings. So all of that is a great note to close on. We are at time, so unfortunately we won't be able to get to some of the questions that were really raised, but I'm really glad that Farhad, you have mentioned if few different sessions that our attendees can join to continue to learn about some of the work that you've talked about, and particularly the diagnostic tools and other dimensions of treatment for sepsis. I'd like to take a special thanks to all of our panelists who've joined us from different parts of the world to really bring this intersectional conversation of diverse perspectives. Clearly, there was some strong messaging around we need political leadership, we need the political commitment. We clearly have some already at the high level with political declarations and government agreements, but now we need to translate that into real investments at the really structural level and the health workforce level, but also doing this with an equity lens, addressing gender aspects, but also other social stratifiers, including stratifiers by race, and really, great data presented early on about realities in the United States, and then just looking at the dimensions from an intergenerational age aspect and the role of environmental drivers as well. So a lot of food for thought, but hopefully this is leaving you feeling energized so that you can go on to look at the issues of sepsis from a broader intersectionality lens, and also looking at different opportunities. In closing, we invite all of you to visit the World Sepsis Congress website, sign the World Sepsis Declaration. Please follow the community on Facebook, Twitter, and Instagram. And thank you to all of our sponsors for really making today's session and this Congress possible. Thank you.